The blood supply to the parietal pleura comes from diaphragmatic arteries, that is the phrenic artery. The mediastinal parietal pleura is supplied by posterior mediastinal and bronchial arteries, the internal mammary artery, and the superior phrenic artery. The costal pleura is supplied by the anterior intercostals and the internal mammary. The arterial supply to the visceral pleura, the entire convexity of the lung surface and a greater part of the diaphragmatic lung surface are supplied by the pulmonary artery, while the bronchial artery supplies the mediastinal, interlobar, and part of the diaphragmatic visceral pleura. The anatomic connection between the pulmonary artery and the bronchial artery is one way that the ischemic lung can receive blood supply via the bronchial arteries, distal to the occluded pulmonary artery. However, in my experience, this is not a common pathway or a significant one. Another way that the pulmonary arteries can interconnect is via the supply to the pleura. In this case, note that there was ischemia to the right base, and we can see retrograde filling of pulmonary artery branches from a selective right pulmonary artery injection. This is because the patent pulmonary arterial vessels via the supply to the pleura connect with the pulmonary arteries that are patent distal to the one that is occluded. So this is in essence interpulmonary arterial anastomosis. This is a close-up of the right base of this patient who had thromboembolic disease. Note the blunted right costal diaphragmatic angle. Note the area of oligemia in the right base, and note that there is a blush at the level of the pleura and retrograde filling of pulmonary arteries that are in the right lower lobe. In this patient with right upper lobe oligemia, one can fill in a retrograde fashion branches of the pulmonary artery via the intercostal arteries. This is another collateral pathway called extrapulmonary. The intercostal bronchial trunk supplies the first aortic intercostal, and because of pleural adhesions, one can bridge the gap between the parietal and visceral pleura. And because of the blood supply to the visceral pleura from the pulmonary artery, when this gap is bridged, it is possible to see passage of contrast from a systemic artery, that is the intercostal, into the lung, and filling of the pulmonary artery distal to areas where it has become occluded. This we can see with infection. We can see that also with ischemia to the lung.